It's nice to have you here today.
Thank you for having me. I'm happy to be here.
So if you don't mind, Dr. Mouabbi, maybe you can introduce yourself a little bit, let our audience know kind of your passions and your interests.
Of course. I'm Jason Mouabbi. I'm a breast medical oncologist at MD Anderson Cancer Center. I'm currently co-leading our hormone-positive working group, where basically this is where we sit and strategize about what studies we would like to open and accrue our patients when they are dealing with hormone-positive breast cancer, both in the early and metastatic setting. And also my niche is invasive lobular carcinoma, a very important subtype of breast cancer that's been historically understudied. And currently I'm chairing the Lobular Breast Cancer Alliance to help get more funding for studies specifically for that subtype of breast cancer. This HER2 law was introduced for the first time with the emergence of the DESTINY-Breast04 results. And it was really interesting because a lot of people believe that there is no such thing as HER2 zero because HER2 is expressed in all cells of the body. So is there truly a zero type, or all of them are low, but some of them are more low than others? So again, it's very interesting, and it's still an evolving field, especially because the current techniques that we use in measuring HER2 status were not made to measure the difference between 0 and 1+. They were more measured to detect who is truly HER2 positive, like those 3+ from those that are not as 3+. And there is a very nice paper in JAMA Oncology that took 18 experienced pathologists. So these are the pathologists that sits on big national, international clinical trials as a central reviewers. And they gave them multiple cases, and they want to see the concordance between 0 and 1+. And the concordance was only at 26%. I mean, these are experienced pathologists that do the central reviews, yet they could not agree between themselves what is truly 0 and what's 1+. So that tells you that we need to do a lot better, especially that we're having this amazing therapy that, in my opinion and opinion of a lot of people, it is like an inflection point in the field of hormone-positive breast cancer. So there's the era of before trastuzumab deruxtecan, and there is the era after trastuzumab deruxtecan. That's how important this therapy is in any patient that's suffering from that disease.
Really, let's start with DB04, DESTINY-Breast04. Maybe you can overview what the trial studied,
yes,
and then maybe some of the outcomes from that study.
The DB04 was really a study for the hormone-positive HER2 low more than just HER2 low in general. There was a small subgroup of patients that we used to label them triple negative, but they're triple negative HER2 low. But it's mainly a study for still the hormone positives. So patient qualified to be on the study if they were labeled as endocrine refractory and have received at least one prior endocrine therapy. So this is the population. Again, mainly the primary endpoint of the study was in the hormone positive subgroup of patients, and it compared to standard of care single agent chemotherapies. And that study got a standing ovation at ASCO 22. I mean, it was amazing to see. I've never seen it. I've been attending ASCO for a while. To see such a drug get a standing ovation, and that speaks to how important those results were. They really improved the outcomes. When looking at the median PFS, it was almost double. Like it went from about 5 months to 10 months with a hazard ratio of 0.5. So 50% reduction of the risk of progression or death by using a trastuzumab deruxtecan compared to treatment-efficient choice chemotherapy, which was huge. I mean, something we don't see before. And what I was really excited about is look at the response rate. I mean, response rate above 50%, whereas with chemotherapy was less than 20%. I mean, very, very, very impressive and very nice to see. And especially when you look at the OS data, where the median OS was about 2 years. Mm-hmm. I mean, that's the median. So some patient that 50% of the patient did better than that, more than 2 years. In a group of patients that we label as endocrine refractory, that is, in my opinion, the area of most unmet need at this point in time. Because those patients, by the time they become endocrine refractory, unfortunately, their tumors are very aggressive, very heterogeneous. It's really hard to treat and manage. And a lot of patients succumb to that disease, unfortunately, at that point in time. And seeing a drug that comes to those population with a median OS of 24 months, that was amazing to see.
I was in the room, and when Dr. Modi presented those, and it was really striking to have maybe 20,000 people in the room all stand up and recognize it. And these are the most dispassionate, critical people you can find on data. And for them to stand up was pretty, I think it just underscores what you said, how important this result was for our field.
It was really important to move it early on, but the DB06 added a lot more. The DB06 not only looked at that, but it looked at a new entity, the ultra lows. And the ultra lows were defined with those patients with faint or incomplete staining of less than 10% of the cells. I mean, this is how specific they went. And about 20%, like 1 in 5 patients, belong to this ultra low category. And it met also its primary endpoint. I mean, it showed great improvement. Again, you see almost 5 months improvement in the median progression-free survival, which is excellent to see. I mean, it went from about like 8 months to 13 months. I mean, it's excellent to see, with also an impressive hazard ratio above about 0.6, also impressive overall response rate in the ultra low as well. So if you look at the HER2 low, the response rate was about 56%, and the ultra low was in the 60% range. So that was amazing to see. There's a study that was published that was at last ASCO, and it was very enlightening for me. They took 512 patients who were HER2 zeros, and they found with every biopsy, the chances of converting to a HER2 low was about 35 to 40%. After 4 biopsies, 99.6% of patients eventually had a HER2 low at some point in time. That tells you that those HER2 zero, this 1 out of 10 patient that doesn't belong to this HER2 low or HER2 ultra low, by just doing enough biopsies, they will eventually get it, and they will get a very important drug.
In that trial, though, the comparator, I'm playing devil's advocate. In that trial, capecitabine seemed to be the most common comparator, right?
60% of the
So
time.
convince me, I'm a community doc. Cape, I'm gonna write a prescription. I'm gonna send you home. It's easy. Convince me. Like, what would you need to see to say to everybody, no, the T-DXd is the right answer in this scenario?
I always tell, especially fellows ask me this question a lot, and I hear this question, this phrase a lot, keeping a certain therapy in my back pocket for when I need it. And it really makes me upset when I hear that, because at any point in time, you want to give the best therapy available for your patients, because you have a window that you can treat those patients. You might lose this window forever. Those patients that go on capecitabine, you don't know how they're going to end up after capecitabine. Are they going to be healthy enough to receive the most important therapy in their journey in the fight against cancer? If you have a better medication at that point in time, you should give it. You have a duty to your patient to give them the best available therapy, or at least offer it. Offer them all the options, but show them the data. Having a drug that almost doubles the benefit or the outcomes over capecitabine, because that was the comparator at the end of the day. 60% received capecitabine, and T-DXd was better, and a lot can argue very well tolerated as well. Would you still go with capecitabine? I like to follow something called the mom's rule, and that I follow to all my patients. How would I treat my mom? If I was sitting with my mom, how would I treat her? I would always give her the best treatment available. And it's very simple here. There is a treatment that's superior than the other treatment, proven on a big international study. They shouldn't pick one over the other just because it's easy for them. They should look at their patient and do what's best for their patients. There is a lot of studies now being open trying to cure first-line HER2 positives. One of them is a TBCRC study that's about to open. So talking about cure and talking about prolonged deep responses, should we really give T-DXd until further notice? That's going to be a big challenge. We know it's going to be positive. We know it's going to be a good study. But is it really going to persuade community oncologists about switching in the first-line setting, especially that the current treatment works well and you don't have to give chemo for a long time? I think that's going to be the big issue with that study. You know, oncology is still a lot an art.
Yeah.
Although we like to stick to studies as much as we can, I can tell you that's one of the fields in medicine that's truly an art. And I can tell you a lot of physicians will do that. If their patient achieve a clinical complete response, they're going to be like, let me de-escalate, go into some maintenance like HP, Herceptin and Perjeta, and then because the tumor never progressed on T-DXd, if in the future there is a disease progression, I can go back and reintroduce T-DXd. So I hear that a lot in the background, and that's something even sits well with me, to be honest. Until now, with THP, even the patients who are labeled quote-unquote complete clinical complete response will get a recurrence in a good substantial amount of time, not insignificant, in the brain. And that's because we know that THP as a regimen doesn't have a very good brain penetrance, right? So it'll be nice because T-DXd, and that's maybe a segue to the DB12, can have very good brain activity. So maybe it can reduce the recurrences intracranially. And that's something I want to look for in that.
So yeah, that's the big news.
Yeah,
We're going to, in a couple of weeks here, we're going to hear about DB12, which I think meets a data gap that we've all been struggling with, which is in patients who have brain metastases. You know, we get all this data around small molecule inhibitors and this interesting signal with drugs like T-DXd that could be effective, but we really need prospective data. So maybe fill us in on DB12.
Yeah. DB12 it's an excellent genius design. So it's a phase 4 study. So it's post-marketing basically. They're including patients with 2+ lines of therapy, HER2 positive, but they're including with and without brain mets. The interesting part is that they're including patients with untreated brain mets and patients with stable brain mets. So very similar to the tucatinib HER2 climb studies population, which is really interesting because from clinical practice, and we learned that really from clinical practice and from small studies like the Tuxedo study, that trastuzumab deruxtecan can have a very decent activity intracranially. And I can tell you from anecdotal clinical experience and from other case reports that are published, it's been working really well with patients with either intracranial disease or leptomeningeal disease, a very hard to treat subtype of breast cancer when it gets to that. And it's shown amazing activity. And it's really nice to have evidence on study that this is true. So having a post-marketing phase 4 study, taking those all-comers patient and looking at those special population with brain mets will add immense value because at least you'll have evidence based to the practice that's already being done.
I think we think about the brain-blood barrier as being very, very difficult for big monoclonal antibodies. T-DXd is a monoclonal antibody at its core, right? But as an ADC, you know, I think what we're actually learning, and we're learning this, is there's a blood-brain met barrier that is not the same as a blood-brain barrier. And so these drugs might have an actual opportunity to get in and deal with people whose burden is in their brain.
Yes, 100%, 100%, which is very important because eventually, if you look at the history of or the trajectory that a patient with HER2 positive metastatic breast cancer will get, 50% of them at some point will suffer from brain mets. So it's really important to get those drugs that can permeate the blood-brain barrier. But you're right, it seems to be more leaky, this blood-brain barrier around tumor sites.
Right.
I remember when I was in residency, even as a medical student, we kept saying we need this silver bullet that you can hit the cancer and spare the body, right? And the ADCs is the closest we've gotten to this, where we're trying to hit the cancer and try, quote unquote, spare the healthy cells. And I'm very excited for my patients, very excited for all patients suffering with metastatic breast cancer, because the future looks very, very bright.
Well, Jason, it's been awesome sitting with you, learning about this, and I think I'm glad our colleagues are going to be able to hear in on this, and I'm also hopeful that patients will also hear your enthusiasm in your voice for what we have and what's about to come, and really providing that optimism for everybody. I really appreciate that, Jason.
Thank you, my pleasure. Thank you.